Okay, well, thanks everybody who's joining us today. We're going to have our clinical Q&A right now. I'm just going to give a brief introduction to the folks we have here, our collaborators. We have Dr. Katie Kompoliti, who's a professor of neurology at Rush University Medical Center, Dr. Daniel DeLuca, assistant professor of neurology at Washington University in St. Louis, Dr. Amber van Laar, VP of clinical development at AskBio, and Dr. Eva Stankovic, who's at the University of Belgrade. My name is Ann Bagchi. I'm a professor at Rutgers University, and my association with MSA is primarily practical in the sense that my mother has been living with MSA for about 8 years. So I'm just going to start in with some of the questions that have already come in, and any other questions that come in during the course of the talk, people can put into the chat and they'll get forwarded to us. I wanted to start with Dr. DeLuca. This kind of relates to your talk as well as a talk that was given by Dr. Kuhn, who wasn't able to join us. So Dr. Kuhn's presentation talked about environmental factors associated with MSA. And a lot of the factors seem to be related to chemical exposures, pesticides, things like that. And it made me wonder, wouldn't, in that case, you expect to see some disparities in diagnoses? For example, more cases of MSA in migrant workers. And what related to kind of what you were talking about in your talk is it possible that the unequal distribution of neurologists could be masking potential biases or disparities in MSA cases? That is because people who are more likely to be working with these types of chemicals live in areas where there are fewer neurologists. Is it possible that they're more likely to be misdiagnosed?
Yeah, thank you for the question. I think it's a possibility. I'm not completely aware we have enough data to say with confidence if that is the case, but definitely we know that MSA is underdiagnosed, and especially in an area like the United States, where we have a very special healthcare system, where some people are not completely able to see a neurologist, or especially a movement disorders neurologist, or that may take a few years. So there is definitely disparity, I would imagine, in terms of diagnosis, and potentially some individuals that are exposed to some chemicals might not see a neurologist as fast as they should be. And if we also consider that some of these individuals might be in a relatively specific geographical distribution, where perhaps there are very few neurologists, or maybe not even a movement disorders neurologist, that creates an extra challenge for the diagnosis. And obviously, this patient is never going to be diagnosed with MSA. They're never going to enter a research study or have the ICD code that makes them have MSA for us in research and clinical epidemiology. So a very important point, and definitely needs to be more studied, for sure.
I don't know, does anybody else have any thoughts about that they care to share? Or? One question that is kind of related to what you were just talking about. I know this is the clinical Q&A, but I know you're all involved in research. So about what percentage of people living with MSA are actually involved in research? So, all these studies that we're doing are based on very small sample sizes. Are they at least representative of people living with MSA? In the United States, at least. I don't know if people can speak to
actually, I was going to say, I think this is actually feeding into exactly what Dr. DeLuca just said, where, if they have to be diagnosed. And in order for that to happen, they have to be seeing the right people, and then they have to have, access and knowledge of the clinical trials. And without that, then no. So, and I do think that, we just don't know what we don't know. So there could be, a lot of MSA out there that we just have no access to. So I think, this is a problem in many clinical trials, especially in neurology, but with MSA, I actually think this is a huge factor limiting our clinical studies.
But my question was more specifically, of the people we know are diagnosed with MSA, how representative are the studies of those patients?
And this is, again, I think a limitation of just clinical trials is that we're not really good at really getting a diverse population. I know we try, but a lot of this has to do with where you put the studies and where your investigators are, and how good are they at having these discussions with a variety of patients. So we try, I think is probably one of the best ways of putting it. But I think that it's known that this is a limitation in some of our studies. Now, that being said, as far as like the types of MSA or the breadth of MSA, I think that we have that fairly well covered, but probably just not in the diversity that is needed across different type of patient populations.
And since you brought the topic of, oh yeah, go ahead.
No, I think there is always, no matter how hard we try,
Yeah,
there's always, we never capture the rural areas, especially if you talk
exactly.
about pesticides, because these studies are so labor intensive.
Yes.
People, cannot travel every a couple of weeks to come to the urban centers where they take place. So I think the pandemic showed us that if the FDA allowed it, that we could intersperse it with few virtual visits. So, we can make people who come, from the suburbs of the exurbs, more rural areas, able to participate.
Yeah, and that was a question I almost interrupted you to ask, is about the role of telehealth and telemedicine, either Dr. DeLuca, in terms of the clinics, these clinics themselves that you're talking about establishing, or in research studies, what role telehealth can play to kind of fill some of those gaps.
Yeah, absolutely. I think, it's quite obvious that COVID has changed a lot of the way that we provide care and research, and several clinical trials have shifted to a more virtual component. And I believe that if a specific multidisciplinary MSA clinic is designed, it definitely should have a very strong virtual component included in it. And that goes back to the point that Dr. Van Laar and Dr. Kompoliti made, that these patients cannot travel. They have quite a lot of difficulty. Here in St. Louis, we have patients that have to drive 5-6 hours for each single visit. And we often refer them to different providers. And if we could combine this in less visits or combine them with clinical research visits as well in clinical trials, we would make their lives much easier. And we would obviously just make the number of patients in clinical research much higher. And that also goes back to the virtual component for follow-up care and for additional enrollment or follow-up of those patients in clinical research. Absolutely.
You see,
Good.
yeah. So I think, the problem is not the doctors, the patients, or the sponsors. The problem is the FDA.
Mm.
And maybe if we had the task force that could convince the FDA that we're getting the same quality, the same information, the same safety by interspersing some virtual visits, and have the pivotal data points be in person. That's what we need. The FDA needs to be convinced, because there is a huge investment in those trials, and people want to be able to go in front of the FDA if they have good data and market the product. That's what we are all working towards. Mm-hmm. So I think that's where the catch is with the virtual visits.
They're not validated, and so the FDA won't look at them. Yeah. It's a huge holdup.
I wonder if it's kind of pie in the sky, but if it would be possible to train kind of a core of clinicians who could be certified by the FDA somehow to be able to go out into communities and help collaborate with these types of studies.
Oh, we've looked into it. It would be ideal. It's just right now it's resource intensive. But I think that, again, this is a COVID byproduct as well. Is like, okay, well, if I can't get them in the office, can we send someone to them? But you have like a core team that then travels around. This would be ideal, but it's intensive, but something that we have considered.
We did it with the nurses, with the Theravan
exactly
study, right?
Exactly.
It was a little, you had to troubleshoot, but in the end, I think it worked, right?
I think it's going to be the way that a lot of trials end up happening, especially if you want to get the full country, and if you really want a good sense of the population, this is the way to do it. You go to them.
Well,
Yeah.
you would, think the FDA would prioritize that. They want to make sure that the products being developed are going to be effective for everyone, that they would want to try to increase.
Especially for
Ideally.
people who cannot travel. I mean,
Yeah,
some of these people, it's a whole family affair to get them out of the house.
exactly.
So that's a barrier for research. What about for clinical care? I don't know if they're all familiar with the ECHO model of training, like having specialists train primary cares kind of remotely. So you get someone who's a specialist in hepatitis C, for example, who can train physicians in rural settings, let's say, on specialty care for hepatitis. Whether that kind of model might work for some of these, Dr. DeLuca, some of these centers of excellence, if that kind of model could work to at least clinically improve diagnosis for patients who are living in these rural areas.
Yeah, absolutely. I think one of the main points of the multidisciplinary clinic is to consolidate the care of the MSA patient in one place. And by doing that, we could have days that are exclusively for patients with MSA. And in that sense, you decrease the wait times, which can be quite high, at least in some centers here in the United States, to see a neurologist or a movement disorders specialist, for example. And in that sense, having these combined patients in one day or a few days a week, you can also increase the possibility of education, maybe in this way that you mentioned. The idea is that you could train medical students, residents, fellows to see more MSA patients in this specific and it's very specialized clinics, and they could go out there and practice. And I think that's one of the more straightforward and clear ways. I can see how training primary care physicians or family doctors is also a possibility. I can see some challenges, especially being a rare disease. I don't know how many MSA patients these family doctors would necessarily see and keep themselves updated, but perhaps realizing some red flags and key features if they do see patients with Parkinson's disease and instead they have a lot of autonomic dysfunction. And I think having these clinics could potentially provide a better access to those physicians and also for their education and awareness. That's the whole point of creating those centers.
Yeah, I was going to say it's just the thinking about it, right? I mean, the MSA is not known by a lot of more general practitioners, and if you even start to introduce the idea that there is this other potential diagnosis, that could then help get to the neurologist a little bit faster. I think that's a huge advantage.
Dr. Kompoliti, so there was a question that was given to me about a patient who has advanced disease and who experiences constant dizziness. Is that a function of NOH, neurogenic orthostatic hypotension? Or
yes. I mean, dizziness is a kind of a dirty word that neurologists hate to hear because it's a very dangerous word if you don't pay attention. It can mean lightheadedness, which is orthostatic, feeling, queasy when you stand up and your blood pressure drops. It can be part of vertigo or inner ear problems, in which case, most of the time you have a spinning sensation, but not necessarily. Or it can be a sense of imbalance. So sometimes it's hard to decipher what is what. But I've seen enough MSA patients who are advanced, especially the ones who have more of the dysautonomia components rather than the Parkinsonism or the ataxia. And I have to say, some of the patients who had, especially in some of the studies, we couldn't get to the 3-minute blood pressure standing. Mm-hmm. I mean, you stand them up, but in 2 minutes, they're down to 60. So in good conscience, we couldn't even get that blood pressure. So can you imagine these people spending their life sitting or standing? So I would assume, without knowing that specific individual, that it's probably part of the NOH, of the dysautonomia.
But I mean, given the way the disease progresses, it could be a combination of all those things, really, right?
Right. I mean, usually the people who have imbalance, they can get up, but they don't have what it takes to take a step or stand by themselves. The ones who have the neurogenic orthostatic hypotension, you can see them. They get the headache. They get, they get that kind of. They don't perfuse their brain, and if you let them standing, they're gonna collapse on you. They're gonna have loss of consciousness.
Yeah, I mean, what I heard from this individual is that there was a feeling of passing out.
Yeah. So that's blood pressure.
Yeah. Okay. For Dr. Stankovic, there were a couple questions about what diagnostic test should be ordered. So, and one person said specifically, we're in Canada, if that makes a difference. I'm not sure if it would, but so let's say you have a patient presenting. Let's say I'm a primary care provider and I've got a patient presenting. What kind of test should I be ordering? And then, obviously we want to make a referral to movement disorder specialist if we can, but I'm in the primary care. What do I do? I think this patient might have MSA. What should be my workup?
Yeah, okay, so thank you for this question. It is really an important question. So according to the new MDS diagnostic criteria for multiple system atrophy, there are actually only three things that should be done in terms of additional investigation. So besides the clinical examination. So first is to evaluate if there is the presence of orthostatic hypotension. So it means blood pressure measurements that can be done using the standing test. So it can be done by any primary care physician. So after 5 minutes lying supine, you should do measurements of blood pressure and heart rate, and then repeat the same examination in the upright position after 3 minutes of standing. And also it is advised that delayed orthostatic hypotension can be captured. So it can be a feature of early disease, and it can be captured if the measurements are prolonged to 10 minutes. So after 3 minutes and after 10 minutes in the upright position, the measurements should be repeated. And then the physician should see whether the origin is neurogenic or non-neurogenic, but this will be presented in my presentation, so I'm not going to go into details here. The second thing that could be also done at the primary care level is bladder ultrasound. So the reason why we do this is because we want to see if there is a post-void residual volume. So it can be done using a bladder scan or using bladder ultrasound. And the third examination is MRI, which is, I'm not sure how it is in the US, but it is usually performed at the secondary or tertiary care level in the Europe. But this is, so conventional brain MRI is the third thing that should be done for the diagnosis of MSA according to the criteria. There are also additional tests, but these are more advanced and not really featuring in the criteria.
I wanted to give Dr. Van Laar an opportunity to talk a little more about the clinical trial. I know there were several questions about that. One was, we're interested in the trial, but don't understand the depression disqualification. And then another one is where the trial is taking place. Specifically, this person was asking about work being done in Spain. But if you want to talk about some of these issues.
Oh yeah, let me start with the question on depression. So depression in of itself is not disqualifying. We are looking for like severe depression. This is a very difficult study to do, and we want to make sure that if there is depression present, at least it's medically stable and that it doesn't appear to be severe. There are a lot of other features like this that are in our inclusion-exclusion criteria. Really just trying to make sure everybody is safe to undergo its brain surgery. So we're really looking for, mostly from a safety standpoint. In regards to where the study is occurring. So right now, unfortunately, this is a US only study, but we are interested in moving into EU. And this will probably be for the next stage of the study though. But we do have actually a few more sites that have opened up since this presentation was given. And so I would suggest to anyone, please go look on clinicaltrials.gov or the Fox Trial Finder to look for some of the new locations. We have a few other sites that are also coming up as well. This is a very small first in MSA study. And so it's really limited. This is also why we're being very restrictive as to who is in this study. So I appreciate everyone is interested and eager, but this is our first time trying this in MSA. And so we're being very, very cautious.
So Dr. DeLuca, someone had posted a question. What's the importance of multidisciplinary clinic for research? I think we kind of touched on that. Do you want to talk more about the role that you see? What are another related question is, what are some of the challenges to running in multidisciplinary clinics? If you want to talk more about some of those issues.
Yeah, absolutely. And I think most of the answers are probably related to the United States, but can probably be expanded into different health systems. But I think one of the main challenges is probably funding, unfortunately. And we know that that's quite challenging, but to deploy several healthcare professionals to one specific clinic for a relatively rare disease, you need funding. And many hospitals are not necessarily able to provide that, and they're not willing to necessarily invest this for you to see these few patients in one day, even though we know at the end these patients are probably going to have a better care. At the same time, you need these healthcare professionals to be with you. So you need to find a palliative care physician or urologist or a social worker that you're going to be able to use in your clinic to provide better care. I think those are probably one of the main challenges, but from the experience of other centers, once that is provided, and many times the funding has to come from philanthropy or from research grants, then you do see a very high number of patients that come to the clinic simply because of the high need of this patient population. And obviously, there is a significant impact in clinical care for these patients. And at the same time, it's very likely that you can use the same structure to provide a better research care and enrollment in clinical trials if you have a social worker that can, for example, call patients for you or find patients that are eligible. If you have more patients coming to your clinic, if you have already a team of physical therapists or psychologists or palliative care physicians that can help guide you in terms of follow-up, enrollment, and new research ideas for this population.
So I know, of course, since MSA is so rare and it's overlooked, the idea is to focus these centers of excellence around MSA specifically, but is it possible to get more funding if you make it a little bit broader, like alpha-synucleinopathies, or is that a possibility, or is it just that you want to focus, we need so much focus on MSA as a rare disease?
Yeah, I think if you do broaden it to alpha-synuclein, then you're going to see Parkinson's disease basically all the time, because that's the most common one, and that's the one that we see in clinic most of the times. There have been efforts by some institutions or societies like Cure PSP that they have already done these clinics for PSP, CBS, and MSA, but that is quite broad, and there is a different need for specific populations. And I think as we move forward, patients with MSA might have very different needs than patients with PSP, for example. They have a very different cognitive profile. They have a very different autonomic dysfunction profile, and that needs specific types of service like urology or a different type of rehab that I don't think a very broad clinic would be able to provide in terms of excellence.
Can you expand on that a little bit more? What are some of the very specific needs of patients with MSA versus patients who have these other similar conditions?
Yeah, I think when we're talking about the most common condition that we see in our clinic, which is Parkinson's disease, we all know that the progression of MSA is much faster, and that the survival span of patients with MSA is also much shorter. So because of that, I believe the involvement of palliative care physicians or even mental health practitioners to deal with this disease is very important. It's a disease that completely changes a patient's life in a very quick and unexpected way. Therefore the importance of these professionals. And as the name implies, it's multi-system. It affects the bladder, the blood pressure, and we need, therefore, urologists and someone to deal with the autonomic failure. That's likely a movement disorders neurologist or autonomic specialist. It's definitely potentially among all of these conditions the one that needs the most this type of multidisciplinary care. We're also talking about sleep, for example, that patients with MSA can have sleep difficulties that are quite particular to MSA and not to Parkinson's disease or PSP or other neurological conditions. So there are very few specific points that would justify having specialized and multidisciplinary type of care.
All right. I want to make sure I answer some of the questions that have come in through the chat. One person has asked, have there been any great breakthroughs on pain management for MSA? And this is kind of an open question, whoever wants to take it, I think.
So pain management, that's, I can try. Are they more specific? What kind of pain?
No, just general. Any ideas or breakthroughs for pain management? I know, like
I don't think there are specifics about pain management in MSA. And pain can be either musculoskeletal or neuropathic. So in terms of musculoskeletal pain, which is kind of, it's similar to what most individuals in their 60s, 70s, and 80s go through. I don't have, there's no specific research in MSA, and we can kind of, depend on the same, mostly painkillers, anti-inflammatories, if possible, avoidance of opiates. When it comes to neuropathic pain, we have very few specific drugs we're using. One is gabapentin, and the second one is duloxetine, and the third one is pregabalin or Lyrica. And I don't, to my knowledge, there's no specific, I haven't seen specific needs to do pain research for MSA in particular.
the coat hanger pain is fairly.
Oh, the coat hanger, we have to fix their blood pressure, right? Yeah, I mean, it's
that's the only kind of pain.
So yeah, that's the only pain that's specific, but that needs to fix the blood pressure. You need to make them perfuse their brain when they stand up or sit up. And there is research going on now.
Okay.
Yeah, we're starting the study.
Okay.
And I have to say, I've had a lot of patients who liked this product. There were a lot of disappointed people when the study was terminated last time. So we are hopeful.
There was a question here. My daughter's 49 years old and believes she has MSA since 2019. She recently had a tracheotomy, which has improved her breathing, but she's been turned down for the trial, she was devastated by this. Why do trials need early patients?
I will start here, and I can't speak for every study, and I'm not sure if this was in reference directly to ours. But for what we are trying to do with a growth factor, we are trying to preserve what's there, and it's always better for us to try to make this approach with a growth factor like GDNF in a patient whose brain hasn't been as devastated by MSA. Now, I think this is the goal maybe of other types of studies, but I think particularly for what we're doing with the neurotrophic factors, this is really critical for us to really make sure that we're giving the best chance possible to see if this drug is providing benefit or not.
Yeah, and I think our experience from the Parkinson's studies, from the fetal transplants to the gene therapies, all the studies that have failed to reach their primary outcome, if you did a stratified analysis of the early patients, you saw a signal that it may work better. So it all comes back to the old saying, you need something to work on. You need a substrate to work on. And if the degeneration is advanced, you cannot prove disease modification if you don't have the substrates.
Yeah, and just to add to Dr. Kompoliti's point, that in many of the neurodegenerative conditions, there has been a trend of even trying drugs in the prodromal stages of the disease, including Parkinson's disease. And this is potentially one of the reasons that a lot of the clinical trials potentially failed, is that we have tried it in patients with a late stage, and therefore we didn't have a lot to work on. We couldn't necessarily revive the cells that were already degenerated. And we don't know how early is early, but it's possible that even within the first symptoms might already be too late, and you have to even work on preventing the initial symptoms. And that comes the issue with biomarkers and a very different discussion.
Yeah, go ahead.
Just that, I think I agree that, we are moving earlier, even earlier, not later, even prodromal, in the prodromal stages. What I would say to those people who are left out is just try to stay as healthy as you can. So when we establish those treatments, you are in good shape to receive them.
Yeah, Eva, I don't know if you want to, this kind of as a prelude to your presentation, which of course is going to come after this Q&A, but you do talk about the prodromal category. And, my understanding is that's there specifically for this purpose, to identify patients who might benefit from these types of research. I wonder if you want to talk about that.
Yeah, but the issue with that category is, it is, you are right, it is aimed for the patients in its earlier stages when the non-motor symptoms are overt and there are only mild motor symptoms. But the issue is that this category is not validated yet, meaning that we don't know what is the performance and the accuracy of this category. So it is still in its early phase, it's still a research. So we first need we need to make sure in the prospective studies that this category provides a good diagnostic accuracy. And then in the future, use these patients for disease modifying, for clinical trials with disease modifying drugs.
So I know Dr. George couldn't be with us, which is very unfortunate. His presentation was very interesting. He was talking about how last year there was kind of hope that looking at these different foldings of alpha-synuclein, that there may be ways to distinguish earlier on MSA from PD and other disorders. And it appears that's not really panned out so far, at least. I don't know if any of you can kind of speak to that and how it relates to early diagnosis or just differential diagnosis.
But you mean about the seeding assays of alpha-synuclein? Yeah, they are very I can make a short comment. There are very promising results from the group of Wolfgang Singer and colleagues from the Mayo that these alpha-synuclein strains are actually different in patients with MSA compared to patients with Lewy body disease, so patients with Parkinson's and dementia with Lewy bodies. And then that if you do this test together with the neurofilament light chain testing, you have almost perfect accuracy for the diagnosis of differential diagnosis between these conditions. So this is, of course, a great breakthrough in terms of diagnosis and something which is very, very promising. But I think that more research has to be done. For further research in this. I just want to make a comment that even in prodromal stages, in patients with pure autonomic failure, already at that stage, these alpha-synuclein strains seem to be different in patients with MSA compared to patients with Lewy body disease. So this is really something that we are really hoping for to see more results and hopefully use that in the future as a laboratory-based diagnosis and not clinically based as it is at the moment.
Well, we're already kind of on this topic, but one of the questions there was, are there any new diagnostic tests or recommendations that have come out since, and it was only been a year, right, since the MDS criteria came out, but aside from this research, are there other approaches to diagnosis that are being pursued or promising?
Well, the one we already mentioned. The second one, which is really interesting, is that the group from Germany in their pilot study showed that if you do the endoscopic evaluation of swallowing in patients with MS and look at the laryngeal function, there are irregular movements at that level in patients with MSA, and these movements are literally absent in patients with PD. So these are the results of the pilot study published maybe 2 years ago, and then the multi-center study is recruiting. And some preliminary results that I'm aware of are also very promising. That also, although this is kind of a little bit invasive testing, maybe not so. Maybe not so easy for the patients, it provides excellent accuracy for the differential diagnosis between MSA and Parkinson's also in early stages. Besides that, I mean, there are different tests, but these are like, that comes to my mind first.
I think just to add one more, that has been a lot of the Japanese groups, specifically with imaging and new types of PET ligands, looking also at different ligands to alpha-synuclein, demonstrating a very good accuracy as well in differentiating atypical syndromes like multiple system atrophy from other neurodegenerative conditions. So there is a lot of work on the imaging perspective to try to develop more accurate ways of diagnosing, as well as the methods that Dr. Stankovic has very well described.
Yeah, I'm sorry, I just want to make a comment. Thank you for this. I fully agree. Also, what we know from the meta-analysis at the moment is that diffusion-weighted imaging, so these are sequences that could be done literally in any center. They are at the level of putamen and also middle cerebral peduncle. Increased diffusivity also can help in the differential diagnosis of MSA compared to Parkinson's.
One of the things that Dr. George talked quite a bit about in his presentation as well was how MSA appears to be starting maybe with infections or the seeding that occurs in the central nervous system versus other alpha-synucleins, which tend to be more peripheral. What do we know about that association between, the symptoms that present and what am I trying to say? How the disease progresses? That was one question that came up last night is, how, when you have a patient with MSA, what can you say about how their disease might progress? It seems to me that there's no kind of one path that anyone can follow, that patients are fairly unique, but I'm wondering what you all have to say about that.
Well, if I may make a short comment. So there are several prognostic factors that are identified, and that we know that these factors can contribute to the more rapid disease course. For example, early autonomic failure or MSA-P phenotype compared to MSA-C, and also older age at onset. So these are several components that can maybe guide us in terms of the prognosis and what are we going to tell to the patient. But I agree that there is a huge heterogeneity.
Yeah,
I'm glad that comports with my answer that I gave.
I would also add that some groups have suggested potentially neurofilament light as a marker of progression or severity, but that has been criticized by other groups and also not replicated in terms of biomarkers that can predict how fast and how severe the disease course is going to be. So I don't think we can say for sure that biomarkers like neurofilament light can necessarily predict it yet.
Another question up last night was, and there were a couple of different questions related to transcranial treatment and hyperbariatric therapy, whether or not these are beneficial to patients with MSA. The response I gave last night with respect to these types of questions is this is exactly why a multidisciplinary approach is important, because as patients progress, you need to have a multidisciplinary team that is paying attention to the specific manifestations that that patient is experiencing and can possibly identify ways that without treatment, it might progress in that direction. But I'd like to hear kind of what you all have to say about that.
I mean, not. I can take it. I don't know if you can add to this. So we have some proven treatments and some unproven treatments. So in terms of the unproven treatments, it all comes down to what the risk-benefit ratio. So if you are taking coenzyme Q10, for example, from a legitimate vendor, even though we don't know whether it works or not, it's a low-risk procedure. Mm-hmm. So, and that's what I would say for treatments that are not proven. You just kind of calculate the risk, and it's a perfectly acceptable. Sometimes, the power of faith or placebo is great. And placebo can have the least side effects than any medication.
Yeah.
It all comes down to what risk you're committing yourself to.
Specific question. My fiance suffers daily with extreme pressure in his head, behind his eyes, and severe headaches. Blood pressure related cause has been ruled out. Where else should we be looking for the cause?
Headaches?
Daily extreme pressure in his head, behind his eyes, and severe headaches. And apparently blood pressure is not seen to be a reason for it.
That's not a reason.
So what else might be causing that?
I mean, I would look at the specific headache types. I mean, people with MSA can have two problems like the rest of us. If it's not blood pressure related or position related, there may be tension headaches, for example.
What about any tests that can help better identify headache types? I mean, aside from a brain scan to make sure it's not a tumor.
An MRI is probably. And then, if your neurologist or your primary care cannot handle it, then maybe you need to go to a headache specialist.
So here's a kind of a personal question. When you have a patient whose disease has advanced and a lot of the treatments become refractory, like how do you talk to those patients? Patients who say kind of every day, oh, how are you feeling? Oh, I'm feeling very dizzy, or I'm feeling this, or I'm feeling that. And you've kind of maxed out. Like, what do you tell those patients? How do you address their concerns? It's not very comforting to say, well, we've tried everything and there's really nothing else we can do for you. That's not it may be true, but it doesn't provide a lot of comfort to the patients or their families. How do you personally maybe deal with situations like that?
Yeah. When sometimes when you're at that point, you're close to what we call palliative care. When you kind of address symptoms without trying to solve them. I personally never tell the patient I have nothing to offer, even if it's true, because you can always try. I mean, you can always try things to alleviate pain, discomfort at any level. And the objectives of treatments keep shifting. I have a colleague who has dedicated her life into advanced Parkinson's and Parkinsonism plus. And that's what they do. They alleviate symptoms. They're more about making people comfortable and treating symptoms. So I think there is a big, gap there in our care, and there is room for people like that. And the virtual visits help so much with this type of care.
Yeah, and I would agree with Dr. Kompoliti that the medication is one part of the care, and you can always try different approaches. But I think it also goes back to our discussion about the multidisciplinary care and having the assistance of other healthcare providers that can also guide us and help us in the management of patients with advanced MSA, including palliative care, but also rehab therapies and as well as mental health support. And there are always ways that we can try to improve quality of life without necessarily trying new medications. It's just one component of the care that we provide as neurologists.
You were talking
Just add real
Okay.
quick, some of this is also the family dynamic too, and whoever the caregivers are, they have to be a piece of that puzzle as well. It's a family disease.
Mhm.
I was just gonna,
It's
What I was
doesn't affect only the patient.
exactly.
at a person at my personal level. So my mother, her disease is advanced enough that she has trouble swallowing. Her speech is, kind of a whisper. She mumbles a lot, so it can be really hard to understand her. But the nursing home where she stays has a music therapist who comes in on Fridays, and my mother is Irish by ethnicity. So the young lady has learned some Irish songs, and when she comes in, my mother sings along with her, and you can hear, like, then she can really pronounce. And so it's interesting what you're saying about placebo, and it's just kind of maybe just the distraction and what she enjoys, and bringing in that family component. The other thing that was very touching was I showed her, I don't know if you've ever seen the Carol Burnett show and the Siamese elephants, the Tim Conway talk about, or the little skit about Siamese elephants. If you haven't seen it, I definitely encourage you to look it up. But we showed that to my mother, and she was roaring laughing. So it's nice to find those kinds of things that really connect with them. I just wanted to make sure I got to this question for Dr. Van Laar. The question says, how does GDF expected to benefit the MSA brain? I'm trying to interpret that question. I'm guessing what the question really is what does it do? What does the gene therapy do?
Yeah, I mean, there's lots of different types of gene therapy. The one that in particular that we are using increases the amount of GDNF back into the brain. So all of our brains have GDNF. Turns out that patients with MSA tend to have very low levels of GDNF. And so we're supplementing that back. Now, part of this is, the different cell types that are involved in the pathogenesis. So what causes MSA? So if there's one cell type that actually makes most of the GDNF in our brain, and those are the oligodendrocytes. And if they're sick from MSA, they're not able to make that GDNF. So now we're asking other cell types to make more GDNF. Now, with more GDNF out in the system, the nice thing about it is it's secreted. So it doesn't just stay where it's put. It actually can help benefit the cells that are nearby. And so the hope is that this is a growth factor, a neurotrophic factor. It's food for brain cells, basically. And so by giving back, this beneficial growth factor, the hope is that it makes the cells healthier and can handle the synuclein a bit better, and can handle the energetics as well in a better way. The other advantage that we have with a gene therapy approach is, we actually can benefit the entire nigrostriatal system. This is why we're looking for patients with Parkinsonism predominantly, because from our experience with the Parkinson's disease studies that we've done, we can see actually benefit all the way back to substantia nigra as well. So this is, a lot of ways in which we think this approach will be beneficial for patients with MSAP specifically.
Another question I want to make sure I got to, with regard to UTIs, are there any new treatments or developments as pertaining to MSA specifically?
I guess probably I should take this, right? Even though I'm not a urologist. So, but coming back to the interdisciplinary team, I've had, and I'm gonna kind of sideline this question. Sometimes I have a hard time referring my patients to cardiologists unless they are, they know dysautonomia, because people spend their whole life addressing high blood pressure. And even the cardiologists cannot understand that these people need perfusion and that low blood pressure can hurt you now, high blood pressure can hurt you in 10, 20 years. Same thing with urologists. We are lucky in the last few years to have a urologist who sees all our patients with Parkinson's, with MSA, and understands what's going on with these people. Understands that, you know, half of the pills we give for bladder make you confused, affect your memory, your cognition, and the other half affect your blood pressure, which can be a big problem with MSA. I would say, considering that the treatments for bladder are retraining the bladder, medications, Botox, nerve stimulations, catheterizations of Foley, or all kinds of catheters, the new things are probably some medications like mirbetic, medications that can affect the smooth muscle without affecting the external sphincter of the bladder and without dropping the blood pressure or making people more confused. And that's not even very new. And the other one would be the botulinum toxin injections, if people are candidates. And that's also been around for a few years. But I say, rather than new therapies, you need the urologist who's seen few patients like you and understands, you know, what's going on.
I can totally sympathize with what you're saying about cardiologists. Specialists kind of get into their way of thinking about things, and it can become problematic. I serve as the medical proxy for my mother, even though she's out in Iowa. And so I can't tell you how many times I've gotten calls from the nursing home saying, you know, the pharmacist was doing a review and your mother's blood pressure has been normal, so they want to discontinue the midodrine.
Yeah. Especially when patients spend their life, their time in bed. You know, we have people who land in the hospital with a UTI and they discontinue all their pressors, midodrine, droxidopa, and then they try to send them to rehab and they don't resume those drugs. And people are passing out right and left because they don't understand the problem. If you're in a bed the whole day, your blood pressure is going to go up. That doesn't mean that when you're ready for rehab, you just have to resume everything. And don't get scared with the 150s, 160s. That's where you should be probably. And finally, don't overreact to a single reading. Because the problem with dysautonomia is the roller coaster. Things go up, down. So you have to address consistent patterns, not overreact to a single reading. And I do readings, I do a lot of blood pressures in the beginning to diagnose NOH, and then I discourage them from doing blood pressures. And even in the study, we didn't have as many blood pressures as the study goes on, because people tend to overreact to momentary readings that are going to be different 5 minutes from now. And you kind of end up chasing your tail.
Absolutely. We're coming to the end. There's one other question here I want to make sure we got to. My sister has pretty severe dystonia with excruciating right arm pain. This is not sustainable. We've tried many medications. It's working. Appointments for pain management clinic and palliative care are over 4 weeks away. Is this type of pain common in MSA? So again, it's excruciating right arm pain.
I mean, it will be hard if you don't see the patient, but it depends on how much he uses that right arm, because, you know, botulinum toxin can be good for pain. But botulinum toxin works by weakening muscles, you know, and injecting an arm that you use, especially a dominant arm, requires a lot of consideration. There is kind of you have to pick your battles there.
And then one last question, it looks like, what about laxatives? I know that constipation can become refractory as the disease progresses, but any recommendations on that?
Yeah, I'm happy to help with that as well. That like in many other neurodegenerative conditions, it's common, and usually the first approach that we try is non-pharmacological approaches, increasing water intake, fiber intake, and making sure that you're doing all that is possible to have more regular bowel movements. And if that fails, you can always try, and we initially do over-the-counter medications to make your bowels move better. And that can be done at a lower or higher frequency, depending on the severity of the constipation, which can be quite bothersome to the patient in many situations. And there are new therapies for constipation, some of these oral therapies that sometimes we also get the help from our GI colleagues to help guiding us in refractory cases of constipation, which are not necessarily the most common, but there are new medications that can be tried for that. And oral medications that are a little expensive, I would say, but can still be tried in the cases of severe constipation. But it's very important to keep in mind the non-pharmacological approaches that sometimes have quite drastic results, and we often forget to talk about with our patients in our visits.
And then Dr. Van Laar, there was one question that was put in earlier, the safety of gene therapy. Are there any specific risks people should be aware of?
Well, for the particular kind of gene therapy that we're doing with, it's directly putting this into the brain. The thought is, I mean, it's brain surgery. So I think there's a lot of risks that come with this. This is not too dissimilar to what we see with deep brain stimulation like we use for Parkinson's disease. But in general, this has been demonstrated to be quite safe. The brain is an immune privileged organ. And so I think a lot of the inflammatory responses that we see from systemic delivery, so when you give it like IV, for example, which is what's been used for a lot of other gene therapy studies, we don't have that risk. We're using very small amounts, very low doses, and it's only going to very particular parts of the brain. And so we do not see those types of issues there. But this is also why we're doing studies. We really need to look at, very long term. Right now, we have about 5 years of long-term follow-up from the very first study that was done, and we'll have another 5 years from our second study. And so I feel like we have good data here to back us up that this has been safe for at least our approach and how we're delivering AAV2 GDNF.
There was a question that was in the chat that kind of goes back to the very beginning of the conversation. I know at least to date, to my knowledge, there's no ethnic group or gender that's more heavily diagnosed with MSA. Have there been any changes? And that was specifically directed to Dr. Stankovic, but if anybody else wants to weigh in.
No, it's, you are fully right. So there are no differences in terms of gender, and regarding ethnicity, we need to mention that the MSAP, but this is something that many people already know is more common in a European and North American population, MSAC in Asian population. We don't know what is the reason for that at the moment. We do not have any data from Africa, and there is some data from South America, but still this is not that much. So we need to be cautious with our conclusions. And also regarding age, so we have this, so there is a peak in the incidence of the disease around 50s, so late 50s. And there is no MSA starting below age of 30. So this is what I can comment on this issue.
Okay, we literally have 3 minutes. There was one other question that came in kind of late. My husband has lower back pain just prior to his blood pressure dumping low. Have you heard of that before? He does take midodrine as needed. So low back pain right before a tanking of the BP. Is that anything you've ever heard of? And doesn't sound like it. Okay, well, I want to thank everybody for participating, all the folks who put in questions, and of course, our experts. It's been a wonderful talk. We've enjoyed having you, and we appreciate your participation in the conference.
Yes, thank you.
Thank you, everyone.
Right.
Thank you so much for having me.
Thank you.
Bye.
This weekend.
Bye.
Bye-bye.